a detailed session on end-of-life care. Today we have as our faculty Dr. Roop Gursahani. He's a consultant neurologist and epidemiologist at Hinduja Hospitals in Mumbai. And he is a founder trustee of a forum called FINE, which organizes teaching courses in neurology. And he has done amazing work in the field of end-of-life care. And he is in the steering committee of ELICIT, which is a task force by intensivist, neurologist, and palliative care specialist. So I think Dr. Roop is the best person to talk about end-of-life care to the doctors, because he has worked a lot and he's practicing that, I think, in his own practice in Hinduja. Welcome, Dr. Roop, for today's session.
Hi. Give me a couple of minutes. I am yet to get my in order. Too many things open on my desktop. Sorry. Right. Okay. Thank you once again to Pallium India for having me on. This talk is going to be a little long, maybe about an hour plus. So what I request you guys to do is, as and when you start having questions, please put them up in the chat box. Right. I'll take a break around at about 20 minutes and then again at 40 minutes. And I'll look at the chat box, and if there are any questions, I'll answer them at that time. This is also because today I really have to quit at about 6:20. So if you want your questions answered, don't leave them till the end. Right? So can I share?
Yes.
Okay. Here it goes. Yeah. Can you see my screen?
Yes, we can.
Yes. Okay. Right. So when I talk about end-of-life care, I'd like to begin by making clear that this is something that is important to us, not just as doctors or healthcare workers, but for everyone as a citizen. It's part of our basic duties, rights, call it what you will. And yet it is one of those things that we, like all aspects of that we speak about so little. And part of the reason why we speak so little about death is because everybody's afraid of it, afraid of dying with pain and suffering. And the best quip was by a guy called Woody Allen, who said, "I'm not afraid of death, I just don't want to be there when it happens." So we look at quality of life, and quality of life has to do with well-being, physical health, psychological state, and so on. What about quality of death? What it means is a good life till the very end, and with minimal suffering, which means that suffering has to be measured, and then you can work on improving it. And we also need to think about whether people have rights at the end of life, which are distinct from their rights through life. So remember that palliative care is applicable to all serious health-related suffering. But then towards the end of life, we look at these three terms that are most commonly used. The first is actively dying, which lasts for days, maybe even as short as hours. It's based on physiological parameters, and it is usually irreversible. Terminal care stretches for weeks to months, and obviously ends in active dying. And end of life care is variably defined. In some places, it is limited to 6 months, some to 1 year. But as you can understand, in many patients, it is something that you can really define only in retrospect, and I'll explain that a little further. So terminal illness is one from which recovery cannot be expected with the available treatment, and death is considered to be unavoidable in the foreseeable future. In the case of malignancy, this could be maybe some months to a year, but in dementia, it could be like a decade. But it is unavoidable in the foreseeable future, which is why we use this and do not specify a time duration. And end of life care is when you are taking care of a terminal ill patient, where the focus of care shifts to symptom control, comfort, quality of life, and quality of dying, together with support for the family. And treatments that are aimed at cure and or prolongation of life can actually be stopped. So when people die, and this is probably the most famous graphic in palliative care, these are the trajectories, disease trajectories at the end of life. And this came from a random sampling of all Medicare deaths in the US for a certain period of time. They captured about 92% of deaths in that sample. And in US, Medicare can take care of anyone after the age of 60. So when they looked at this whole group, they saw these patterns. And in these patterns, sudden death, terminal illness, organ failure, and frailty, they identified these. And I'm going to explain them a little further in detail. Now, sudden death, you're looking at a population that is above the age of 60. In fact, anytime after the age of 50 years, less than 10% of people die suddenly. Why is that? That's because all kinds of risky behaviors, all kind of things that can cause sudden deaths. It could be an executive smoking away and not exercising. It could be a soldier. It could be a terrorist. It could be a guy without riding a motorbike without a helmet. All of those risky behaviors usually end by the age of 50, and usually less than 10% of people die suddenly after the age of 50. If you think that's the kind of death you're going to do, you have to do a lot of punya, like our long-haired president. And he died doing what he loved best, somewhere in his 80s. The next major pattern is that of terminal illness, which specifically applies to malignancy. And this is pretty prominent in people in their 60s. It's called the waterfall trajectory because and people can maintain fairly high function until eventually the malignancy breaks loose and is then not amenable to any kind of curative treatment. And then it has a very steep but a very predictable decline. That's called the waterfall trajectory, which is understandable. And it causes about 20% of all deaths, probably declining because we are getting better and better treatments. And I don't need to tell you who this gentleman is, Manohar Parrikar. What about the next major category? This is called organ failure, the looping trajectory. And it's called the looping trajectory because people cycle in and out of crisis, into hospital and out of it. And this affects people who have organ failure due to bad diabetes, hypertension, and they can have any kind of organ failure. These account for about 15% of deaths in the 70s. And because VIPs get organ transplants, this is a common man. And then, of course, you have people who enter their 80s at a fairly low level of function and keep on dwindling down until they finally pass away. And again, so we call this the dwindling trajectory of frailty and dementia. And this is going to be the lot of at least about 50% of us. Atal Bihari Vajpayee lost an election in 2004 and then finally passed away in 2018. We didn't hear anything of him in between. So that was what was happening. But after these 4 trajectories were published, it became apparent that there was actually a 5th trajectory. And this 5th trajectory is something that affects somebody who's otherwise well functioning. It could be somebody in the late 70s, early 80s. It could be a young person. And either something hits the brain, either a stroke or a traumatic brain injury, Or in the elderly, it could be even something systemic like a hip fracture. And they suddenly decline to a much lower level, at which point they stay until they pass away. In all these trajectories, can we foresee and foretell death? Now, remember that even from the time of Hippocrates, it's been accepted that one of our duties is to prognosticate. Prognostication is foreseeing and foretelling. Why? So that men will have confidence to entrust themselves to such a physician. Remember that prognostication is one of our duties. The thing is that as our patients, as our idea of the dominance of physicians has changed, um, people expect us to communicate this prognostication in a fashion that is honest, accurate, and optimistic. And we find that rather difficult to do. So, but if you choose to, you can begin to do this at least at a broad brush level in a lot of patients. So, take for instance an elderly individual, say maybe he's in his late 70s and he needs assistance with all basic activities of daily living. He also has congestive heart failure. And when you go through his records and so on, you find that his serum albumin has dropped below 30. So 1, 5, 6, and 2, 7, right? Anything beyond 6 points has a more than 60% mortality in the following 1 year. What does that mean? If you accumulate that 60%, 60%, 60%, well, it's well over 90% by the end of 3 years, right? So you can predict that this is an individual who is likely, more likely than not, to pass away in the next 1 year, but is almost certain to pass away in the next 3 years. Now, if you do this, if you go through this exercise, you realize that most deaths can be anticipated, though a minority, that 10%, are unexpected. And if you recognize decline, then you can plan this last period well, avoiding crisis admissions, and you give care that people want. And more people live and die in the place and the manner of their choice. How do you do this? If anyone of you is interested, I mean, I'll be discussing this, but I strongly recommend that you look up the gold standards framework from the United Kingdom, which really spells this out in a fair amount of detail. Now, when we look at terminalness, how do we recognize it? And these are the 4 categories of triggers that we use. The first is called the surprise question, and I'll explain that. The second is general indicators of decline. So when somebody's overall functioning is going down, then conditions, various clinical conditions, various organ systems will have specific clinical indicators. And there is a decisional trigger in the sense that if you decide in a given patient that disease directed therapy is going to stop, then that also obviously makes death in the near term more likely. So the surprise question is when you answer no to the following question. Would you be surprised if this patient were to die in the next 1 year? Or would you be surprised with a shorter time frame being months, weeks, days? And remember that this answer has to be intuitive. It pulls together your clinical experience, your knowledge about the patient's comorbidities, and the social and other factors. And you, as you get more and more experienced, you realize, I think I usually get an accuracy of about 75% for myself, which is fairly okay for non-oncology. For oncology, in fact, it crosses 80%. And this has been validated in enough literature for us to know that this is actually an approach that can be used. What about general indicators of decline? So as functional performance declines, this is an individual who stays in the bed or the chair more than 50% of days, with increasing dependence in most activities of daily living. Once they reach this point, then you're looking at survival in a few months only. To do this systematically, you can use these various indices. You have the Barthel index, the Karnofsky, performance score, and so on. This is the Karnofsky score, and here you can see that you can identify bedridden more than 50% of the time is down to 40, right? Uh, Completely bedridden and comatose is obviously 10. So if you put this down, you can actually see how much an individual is declined. And unless you do it systematically, families often don't pick this up. In addition, comorbidities are also a major predictor. So if somebody has multiple problems, so congestive heart failure with CKD with uncontrolled diabetes, well, you know that this is somebody uh, whose survival is difficult. Then disease advancing. This obviously changes from disease to disease, but for instance, in Parkinsonism, severe constipation is something that would make me wonder what is happening now. Decreasing response to treatments. So ILD requiring home oxygen, that is another trigger. Uh, Progressive weight loss, serum albumin dropping below 2.5. 3 or 2.5, you can take it whichever like, but 2.5 is definitely serious. Repeated unplanned admissions. And then comes the sentinel event. So individuals who are otherwise coasting along well will have a sentinel event. And that need not be physical. It could be psychological, the loss of a spouse. And so very often we've heard of people who die within the year after their spouse passes away. So those are general guidelines. What about disease specific? Now, this obviously is most predictable for cancer. So anybody who has metastasis after initial therapies, stage 4 disease, multimorbidities, not available to further treatments, once they spend more than 50% of their time in bed or lying down, their survival is estimated to be 3 months or less. It's quite unpredictable for organ failure. And you can see, you remember that course of they come in, they go out, they come in, they go out. But if you looked at that looping trajectory, you would have seen that every admission is followed by a decline. Nobody goes back to a higher level. So that looping course can go on. And for instance, these are the GSF indicators for heart disease, lung disease, and kidney disease. But let's look at liver disease. What if somebody has a hepatocellular carcinoma, liver transplant is contraindicated, and has advanced cirrhosis with refractory ascites, comes in with encephalopathy, has malnutrition, and also has a bacterial infection? You know that you're dealing with somebody who has a survival perhaps in weeks, but unpredictable. There are people who still do turn around this situation. When it comes to neurology, it actually gets pretty complex because various diseases have different periods of decline, and you may, in fact, find it difficult unless you are a neurologist or you have access to somebody from neurology to help guide you to see when what the decline means. But nevertheless, any person whose functioning is continuously declining to the point that they are dependent, I think that is fairly clear cut. But because neurologic decline, especially when there is dementia, often it is the decisional trigger that matters. So if somebody who has progressive deterioration in physical functioning despite optimal therapy, symptoms which are complex and too difficult to control, swallowing problems, speech problems, it's quite possible that families may decide not to pursue any further active treatment. Or the patient may have had a prior living will saying that this is where I want active treatment to stop. This is because we now have the means to keep the body alive indefinitely should we choose to do so. There should have been another photo here, that of Lata Mangeshkar. These are the two Bushes, Barbara and George. They passed away in their own beds. If you look for pictures, they are literally in Darbar with cats, dogs, children, everybody, the whole family around them in their last days. Poor Atal Bihari died alone in the AIMS ICU. And Lata Mangeshkar also died on a ventilator in the Breach Candy ICU. So the way I put it is, if you are an Indian VIP, you have to die a tortured death on the ventilator. So I'm going to stop here for a minute, check for any questions in chat.
No questions in the chat so
Oh,
far. But
one.
if you want,
Okay.
if anyone wants to unmute and ask any question at this point, you can please.
Yeah, while I catch my breath. 1 minute.
Yeah.
Okay.
Sir, how can we address depression among the old age patients, especially those
Depression
with
depression is a specific clinical diagnosis. So I mean, if you are, if you are able to take a decent history of, the simplest history is to ask them directly, are you sad? Man mein udasi hai kya? Or there will be people who are at this stage of life and are still able to enjoy the small things like family visiting, a drink once in a while. And it's only when they stop enjoying all of that that becomes depression. Otherwise, and then that needs to be treated. So you do have to separate out depression. The more difficult thing to treat is something called demoralization, which is what happens when somebody actually gives up and is not even willing to try anything at all. That is tougher to treat. Depression is something that we can treat with drugs. I'll move on.
Yes, yes.
Okay. So I'm going to explain this to you, this decision making, through the stories of some patients. The first is this old gentleman who in January 2014 was diagnosed with early dementia, and he also had mild depression at that time. He asked his neurologist what is going to happen, but nothing, there was no meaningful discussion. And he had been working till 2 years before, but he had probably internally realized that things were going downhill. And he had resigned from his responsibilities and lived with his wife, with his kids abroad. And as you can see, over the next 3 years, his cognitive and behavioral functioning gradually declined. In 2015, he was independent. By 2016, he started to make mistakes. And by 2017, this is a pattern that we see in dementia, that increasing behavioral issues literally predict the last stages of dementia. And he needed prodding for a bath, nighttime wandering, and so on. And in 2018, the beginning of 2018, he came in with delirium due to urinary tract infection. He needed a suprapubic cystostomy at discharge, but he could still walk. But of course, now he needed to be somebody around for him all the time to make sure that things were done right. His conversation also started to decline. Now it was a wife who asked, "Ab kya hoga?" And again, the same answer: old age. By the end of that year, there was a further deterioration, and he came in with hyponatremia. But after the hyponatremia was treated, in fact, he became bedbound and completely mute, nearly mute. He could say yes, no, call his wife's name, and so on. And then a couple of months later, he came in with recurrent seizures. There was no hyponatremia at this time. So this was a part of the disease itself. He got intubated. The seizures were easily controlled. He could be taken off the ventilator and extubated, but for some reason, which I wasn't able to fathom, he got a tracheostomy on day 8. But it was when the PEG was suggested to the family that they really wanted a prolonged discussion, which is where I also came into the picture. But anyway, that got done, and he was discharged for home care. When he reached home, he was effectively vegetative. And the US-based son actually said, could we have gotten palliative care involved earlier to have this decisions taken in advance? And then he was managed at home. There were bed sores. And then one day in March, vomited. All his vomit got aspirated, and he practically died instantly. So if you look at our gentleman, at diagnosis, this could have been discussed with him. He had retired as a director. He could have been told that this is something that is coming up ahead, and he could have been suggested a living will. Whether he would have taken it, one doesn't know, but it wasn't even thought about. At the first admission, it should have been recognized that he was now on a steady downhill course. And prognosis and goals of care, all of these, because you can then avoid future hospitalization. In fact, I would have said that the seizures could well have been a terminal event. I don't think he needed to be intubated. He perhaps should not have been. He should have been managed without intubation and not kept in the ICU also. And the tracheostomy could definitely have been avoided. Well, whatever it was, he went through everything. And compare that to the next two patients. This is a gentleman with a malignancy. Socially active, only daughter in the USA, gets a colonic adenocarcinoma. And with that colonic adenocarcinoma, goes to the oncosurgeon and the oncologist. Gets a hemicolectomy. And as so often happens, the one sentence I remember from him is that when he spoke to the oncologist spoke to his daughter, would not meet his eyes. This is something that we do so often. We see a patient with a serious illness, a terminal illness, and we don't look at them. We kind of look away from. That is not okay. Anyway, he got his chemotherapy. He just had one little bit of problem during that. And but another thing happened. His US-based grandson decided that palliative care needed to come and talk to him. And immediately after his chemotherapy, this began. Pretty unusual for an Indian patient. The oncologist didn't know that. Anyway, he had a 3-monthly follow-up. And this is February to August 2017. In November 2017, a regular PET CT picked up extensive mets with an expected survival of 4 months. So the oncologist offered palliative chemo and said offered a median survival of about 8 months. For a younger patient with these agents, you could probably get up to 2 years. And uncle decided, no way, he didn't want this. So palliative care came in, hospice care was set up at home. This was beginning of 2018. By April, he was going downhill. So there was a fairly prolonged discussion of the whole family with the palliative care team. And you know what? The grandson who just got a new job got leave because he knew what was going to happen and flew to Mumbai to take care of his nana. He did all the paperwork that was required. They had long discussions, remembered their past things and so on. And as he began to finally slip away, his daughter, who really had no leave, came in and he literally greeted her and left. Think of the difference between these two deaths. Neurologic or non-oncologic death, erratic, prolonged trajectory, recurrent admissions. The problem is in dementia, there's this early loss of personhood. This is one contributory factor, but even otherwise, even if it is, say, liver failure, these people end up getting avoidable ICU care at the very end. In cancer, on the contrary, because whether it is the availability of palliative care in all the large cities and so on, or because of that defined trajectory and prognosis, admissions can be avoided and a conscious patient retains control if there is transparency, right? If there is transparency, if they are told what is happening. What are the diagnoses of old age? Well, remember that human life expectancy is not expected to increase much beyond 80 years, regardless of what anybody tells you. Occasional, these are outliers who live much beyond that. Beyond the age of 80, we are all on borrowed time. And remember, you also have to look at the concept of chronologic versus biologic age. So you will intermittently see somebody who's 70 and looks 60, and you will see somebody who's 70 and who looks 80. And the same, obviously, as the next decade. Remember that sometimes people who are doing well are hit by a sentinel event and things go downhill. So this lady is somebody who I knew fairly well. Uh, in November 2014, she was 80, and her 87-year-old husband moved to live near their only daughter. She had poorly controlled diabetes, and it was because the daughter said, "I can't handle you at a distance. You have to live near me." And she had had episodes of hypoglycemia, but she settled in. The daughter insisted that she had support, and she had a fairly active social life. In April 2016, about 2 years later, she had a febrile diarrheal illness, needed admission to the ICU, but she was okay. But then something had changed. The next thing that happened is that she had a fall at home, a fracture neck femur, needed hip replacement, transient post-op delirium, but now her mobility had gone down. And please look at the individual as an entire organism where uh, you think random things are happening, but there is a decline that is happening. And then um, this was 2014, 2016, 2017. The husband got vague chest pain, mild fever, and when he came into the ICU, into the hospital, he had lobar pneumonia and sepsis. And he literally passed away within 24 hours. He was not intubated. This was confirmed by his wife. Why was this? Because just after she had had uh, her admission for the fracture neck fever and she had been through that bout of delirium, she and her husband spoke to their daughter, made it clear that there were to be no heroic measures for either of them, no life support, and their bodies, in fact, they wanted their bodies to be donated to the medical college. And then after he passed away, her granddaughter came in to live with her, and that to her was in some ways, a major compensation. But about 8 months later, she developed multiple superficial soft tissue abscesses. Throughout this period, her sugars were still anywhere between 150 and 300, very brittle. She was treated with IV antibiotics, admitted twice, but by early March 2018, 2 courses of multiple antibiotics had failed. So she was discharged for home care with daily dressings, and she wanted to know what is happening. She was told the medicines are not working. And her decision was, I won't go to hospital again. In fact, she was a pretty stoic lady. She refused any painkiller stronger than paracetamol. And this happened, this last discharge was in 2018. By end April, her activities were going down. She was in bed most of the time, needed help with all basic activities except feeding. Uh, Reduced appetite, intake of food and water going down. Second week of June, she started to become confused, a little restless, began to moan even on turning over in bed, vitals beginning to decline. 3 days later, she stopped speaking. Um, uh, the first day that she did not say good morning to me, she passed away later that same day. So I hope by now, having looked at all of this, you will understand why in days past a physician needed to let families understand and know what was happening. And if you were not able to do that, you were not trusted. Before the middle of the 20th century, diagnosis, therapeutics, and prognosis were three equally important functions of the physician. As treatments improved, the skill of prognosis declined in teaching, research, and in practice. If you look at Harrison or wherever, prognosis is down to one para at the end of a long chapter. Earlier, it would be about a third. And prognostication consists of two things: foreseeing and foretelling. Foretelling has to combine honesty, accuracy, and optimism in our patients. In Hippocrates' time, you could say, so and so will be dead. Our patients are not going to accept that. You have to communicate. So you need communication skills to do that. You cannot be oracular. And if you do this, remember that these two go together. If you do not commit to foretelling, your foresight will atrophy over a period of time, because you are not able to do this, you will avoid doing this. And that's a major clinical skill that you will have lost. So when you need to speak about the end of life, what do you talk? The first is goals of care. And this is our business. You have to combine it with patient education. So you have to tell them what is happening. And you have to do this often over multiple visits. So you keep checking in, and as you do your consultation, you, in addition to talking about treatment, you figure out what else would be planned. Now, when you take this goals of care to a system where this information is documented and made actionable, it becomes advanced care planning. Now, this is the living will or the advanced medical directive. Ideally, it includes choosing a proxy decision maker for the end of life. Now, in most of the Western democracies, not only is this legally valid, it is enforceable, and it is backed by public policy. So a doctor who takes the time to make this kind of discussion can actually charge for it, right? In India, they have become valid, but they are not yet enforceable, and they're not backed by public policy. Now, when you get all this information, you combine this with your own input about prognosis and feasible choices, and together the patient or family, you make appropriate in the moment decisions using shared decision making, and that is extremely important. What goals of care do you want to set? Well, obviously this is explaining and communicating, but you have to always start out by finding out how much they understand and how much they want to. You have to explain uncertainty. And probably the most important, the first question that you ask is wishes about place of care. Does the caregiver agree? There are times when the patient may say, I want to die on my own bed, and the only caregiver says, I can't handle it. So you may have to look at this, and wishes and plans may change. If you do it well, it improves the patient's quality of life because it gives them a sense of control over managing the last days. It decreases burden, conflict, stress, anxiety, and depression in surviving family members. And for the system, it decreases the use of the ICU and CPR and so on at the end of life. Challenges are fear of death from the side of the patient, difficult to talk about it. From the clinician, it's usually stated as lack of time, but I don't agree. Specific decisions that need to be taken are place of death, mode of feeding if the patient is unable to feed, parental medications other than those required, and basic life-saving treatments. Now, remember that in my patient, families do not see the timeline of decline. And I've pointed this out to you, the way she went down from, actually at this point, I should have predicted that she had some months only, or at least not very long. So families are lay people. They are not supposed to see this. Clinicians do not see it and ignore it. Sorry, or see it and ignore it, or don't know how to handle it. And I've told you this earlier, I'm going to repeat this once again. If you do not know how to foretell, your foresight will atrophy. I'm going to stop again for a no, I'll just finish this. Remember that this communication skill is a learned skill. It's as much a learned skill as surgery or diagnosis. It requires training, it requires practice, it requires assessment and certification, and this can be done in India. And once you have learned, then when you're performing it, like any procedure, you have to prepare, do the procedure, and review and reflect. And this is a picture of me. This is me explaining to one of my senior colleagues that he needs to learn communication skills. And he says, who are you to tell me that? Right? So this is where I'm going to stop for this section and give you about a couple of minutes, because in the last bit is also fairly intense. Any questions so far?
Nothing in the chat. Is there any question?
Okay.
Otherwise, you want to ask? No.
Okay.
Yeah, we can proceed.
Okay. Now remember that there are some rights that every one of us, I said patient rights, but citizens' rights at the end of life. The first is to be treated as a living human being until death, with a sense of hopefulness, however changing it may be. Towards the end, it may just be that I want to stay for the next 3 days to attend my daughter's wedding, whatever. To participate in decisions concerning your care. For that, you need your questions to be answered, not to be deceived. And even though you change from cure goals to comfort goals, your treatment, your care should continue. To die in peace and dignity, not in pain, not alone, to retain individuality and not to be judged, to expect that the sanctity of the human body will be respected after that, and to be cared for by caring, sensitive, knowledgeable people who will attempt to understand your needs. There has been a fair amount of, in fact, there's a very nice new paper which says that actually this is number one. Right. So now, how and where did this deteriorate, or was it ever very good? Anyway, our as medical progress took on from the 1950s onwards, remember that before the 1950s or 60s, there were no ICUs. I think India ICUs came only in the 60s and 70s. And if you got seriously ill before the time of antibiotics, well, it was your luck whether you survived or not. By the end of the 70s, 80s, organ transplant, and people used to ubiquity of survival, which means you could have a serious or critical illness and expect to walk out. What that led to is that death became medicalized because you ended up having people in the ICU towards the end of life or in hospital. Death moved out of the homes, out of the knowledge of people, and it became a purely professional affair. But simultaneously, medical paternalism was ending. Informed consent, patient autonomy, and rights actually crept in from human rights. So the first living will was written by a human rights lawyer. And because the US is a vigorous democracy with multiple states, it became the world's laboratory because it literally was a competition between various states to see who could put out a better living will or see that it was better supported. And eventually the US Congress passed something called the Patient Self-Determination Act, which says that if you are in a hospital which has any kind of funding from the central, their federal government, then at admission, you must be asked if you have a living will or you want to make one. Simultaneously, in the United Kingdom, palliative care began. Palliative care was first put together as a system for cancer patients by a lady called Cicely Saunders, and the United Kingdom then became the hub of palliative care, and these two kind of merged. Now, we all know the four pillars of ethics: autonomy, beneficence, non-maleficence, and justice. But remember that dignity, honesty are also important. Empathy and compassion, fidelity, integrity are also features to be concerned. When you look at these four major headings, it's not very easy to apply them to a given patient. So the way we use them is using the four-box model, in which you look at first medical indications, which usually means beneficence and non-maleficence. Patient preference, where you obviously give first choice to autonomy. Quality of life, where autonomy, beneficence, non-maleficence all come together. And contextual, which means justice. I mean, when you use a scarce ICU bed to ventilate somebody who's brain dead, you're actually killing the next Guillain-Barré syndrome who's waiting for a ventilator, right? So how do we put this in the framework of what we do? Now, the legal framework of India begins with the Constitution of India. We are a common law country. So judges can take from this and make, in a sense, laws. The only law that we have is the Transplantation of Human Organs and Tissues Act, but there are Supreme Court judgments. There are professional guidelines. Remember that judges will follow professional guidelines if the majority of doctors, if these are done properly, they will actually follow them. And then we have all these other acts. I have been involved in this topic since March 2011, when I was on the medical committee for the Aruna Shanbag case, which actually decriminalized this whole process of decision making. In fact, it also spoke about not keeping patients who were brain dead alive. But in that case, at least for Aruna's case, they decided she was not brain dead. She was actually in somewhere between the vegetative and the minimally conscious state. And her next of kin were the nurses who were taking care of her. And he decided that they did not want her to pass away. And then came this major judgment in 2018, which actually clarified the whole, and it is the law of the land now. And it very clearly made it crystal clear that all adults with the capacity to consent have the right to self-determination and autonomy. You can apply the emergency principle only when it is not practical to obtain the patient's consent. But where a patient has already made a valid advance directive, which is free from reasonable doubt and specifying that he or she does not wish to be treated, then such directive has to be given effect to, even if such decision entails a risk of death. Right? So, yeah. So why is it that the medical profession still shies away from this kind of decision making, this kind of discussion? Now, if you ask patients, they'll say this is because corporate hospitals are those in which the poor cannot enter and the rich cannot leave, right? If you ask our fraternity, they'll say, well, Narendra Modi has not told me all this, so I'm not going to do anything of this. How do I know somebody is not going to file a suit against me? There is also the question of difficulties in establishing prognosis. But I believe that the real reason is a lack of capacity. We just don't know how to do this. We don't know how to speak about this. I'm going to drop this and move on a little further. I was part of the DNAR system. So if there is, yeah. And I will now move on to the process, the clinical process of what happens when somebody is actively dying. Another 1 minute, because I skipped over some slides. So if anybody has any questions about DNAR and so on, I can quickly take them. No?
No.
Hello? Okay, so I'm taking on. Okay, so how do we know when a person is actively dying? Remember that these are purely clinical symptoms and signs. So active dying is the period preceding death during which the patient's physiological functions wane. And you need to prepare the family and caregivers for the natural process of dying. The care then becomes multidisciplinary, and we also need to take care of them after death. So months to weeks before death, if you look at what I have been telling you so far, they actually begin by physical and psychosocial withdrawal. If you look at the old lady with the diabetes, she started to sit and remain in bed. Decreased ambulation, withdrawal from family and friends, oral intake begins to decline, and towards the end, incontinence and also appears. But these are physical and psychosocial withdrawal. Once they enter the stage of active dying, the first thing that you notice is delirium. These will be episodes, and together with that, vitals also start to decline. Blood pressure tends to go down, pulse becomes irregular, they become more and more drowsy, and they become completely confined to bed with, well, reduced communication. And days to hours before death, this is imminent death, the vital signs finally start to go down consistently. Obviously, consciousness, the breathing becomes irregular, and because they are no longer able to cough out or swallow their secretions, they pool in the throat, and the death rattle is something that can really bother families. It's scary. We have to tell them that the patient is not bothered by it, it's you who's bothered by it. Hemodynamic changes appear, the face may become relaxed, and there is one thing that I haven't put, yeah. So typically you will see gasping respiration. And if you see mandibular movement as part of the breathing cycle, you know that this is an equivalent for gasping respiration. And the face appearance also changes. And our goals of care now become, well, comfort, peace, dignity, basically to make sure that the carers have a good memory of the dying process. And you have to start, I mean, ideally, towards the beginning of the dying process itself, you have to do a review of the drugs and start taking them off and manage the symptoms. Sorry. When you look at nutrition and hydration, you can understand that this is not a patient who's interested in food or is also going to be able to swallow it. They may also have stomatitis. So what do you do? Well, one thing you do not do is put in a feeding tube. Why? Because feeding tubes do not enhance survival or quality of life at the end of life. A fair amount of literature on this. I haven't quoted that, but please take it from me. Tube feeding is associated with agitation. You need to tie them down. The risk of pressure ulcers increases, and they do not reduce the risk of aspiration or pneumonia because you're feeding them more than they can take. They're likely to aspirate and bring it out. Remember, my patient with dementia died because he puked and aspirated. Decisions regarding artificial hydration have to be made with the patient's best interest in terms of their quality of life. If you do have clinically assisted nutrition and hydration, this means either a rice tube or a peg tube, you have to review the rate of volume according to individual need so that you avoid overhydration. Typically, if there is no catheter, I look to see that they are passing urine 3 or 4 times a day. Ideally, you do what is called hand feeding. Provide the food items that the patient likes. Food may be mashed. You don't really need to use nutritional supplements. What you do need to do is alleviate symptoms of thirst with good mouth care, gently, and ice pieces, and moistening and lubricating the lips. Remember, the body is shutting down and intake is going down accordingly, not the other way around. Total fluid requirement is about 1 liter per day, and I always ask if they're passing about 3 to 4 times urine per day. IV fluids are strictly avoidable. If at all, then you give them subcutaneously because then you give a maximum of 1 liter only. And the aspiration risk actually is smaller with hand feeding or with spoon because, well, whoever is feeding is obviously somebody who's caring for that patient. And they stop when the patient begins to cough. What about medicines? Stop all medicines that are not required for symptom control. Important medicines that need to be continued or are required for symptom control can be given subcutaneously. IV antibiotics are not necessary. Aspirins, statins. Statins are something that, well, look at survival in the next decade. Absolutely senseless. Oral hypoglycemics and insulin can also be stopped. Typically, you will find that the sugars now start to hover around the 100 to 200, even in somebody who was badly controlled. Antidepressants also need to go. What bothers the patient and family are first and foremost pain and agitation. Incontinence and dyspnea also do bother them, and we can actually tackle all of them. If you do need to give these medications, ideally you should be giving them subcutaneously. Pain is the most common symptom. There's varied presentation, and if you cannot assess it verbally, there are validated pain scales. For instance, even in dementia, you have non-verbal indicators. The pain AD scale is actually, you should look at it to identify pain in the elderly. And you have to anticipate and treat it effectively. Ideally, access to opioids is settled, and there's a reliable route to titrate the dose up. If somebody is restless, agitated, then first start by assessing the environment and looking at non-pharmacological options. What I do is first and foremost, I try and see if they're getting enough natural light. Ideally, they should get sunlight in the morning. Lights should be turned off at night. But the next that I look for is these things: urinary retention, constipation, pain, and fever is yet another cause. Some medications can also worsen it. You have to stop stimulating noise and protect the patient's sleep. In case the patient is not willing to talk, don't shout. Just see if they can understand. If nothing works, then non-pharmacological, then haloperidol is the first drug to use. Not benzodiazepines, they actually worsen delirium. What about breathlessness? Well, first start by correcting the correct table. So if there is a fluid in the pleura, take it out. Then remember, air movement on the face, fan on the face, is actually something that helps them quite a bit. You reduce the perception of dyspnea, and for that, either morphine or here you could use anxiolytics. And if somebody is just not, if their breathlessness is refractory, then you do something that is called palliative sedation, and we'll talk about that a little later. Again, with nausea and vomiting, if appropriate, reversible constipation, hypokalemia, and so on. The first drugs are metoclopramide, ondansetron, but also haloperidol. You could also use steroids and lorazepam. You could also use olanzapine. Now, these are not drugs that we normally use in day-to-day practice, except for metoclopramide, which in fact neurologists frown on. But this is not day-to-day practice. You're looking at somebody at the end of life, and your priority is to make them comfortable, not worry about side effects 10 days later. So some of these medications are also available in sublingual and intranasal form. Anyway, the other thing that bothers them is the death rattle, and it's present in 50% of dying patients. In fact, anybody who has a death rattle is usually gone within 72 hours. Now, this can be because of inhibition of swallowing reflexes or because the bronchial secretions cannot be cuffed up. The family has to be told that this is not causing any distress. Non-pharmacological management is basically repositioning. We don't do suctioning. What you do is use a finger wrapped in gauze piece to take the secretions out from the angle of the mouth. If you do need to, you can use glycopyrrolate or hyoscine to dry the airways up. Mouth care is important. Pressure sore prevention is important. These patients ideally should be catheterized, and you need to monitor for constipation. Now, there are two modes of death which most people are not aware of or used to. The first in patients with neurological illness, but also other illnesses, and that's fits or epileptic seizures. When somebody has a seizure, the first is prevent harm. Don't force objects into the mouth. No oral medication should be given because, well, an unconscious patient, it's not going to go down. So subcutaneous midazolam or subcutaneous anti-epileptic drugs, typically levetiracetam is pretty easy to use, but even valproate and phenobarb. And if this is end of life care, then the patient will gradually become unconscious. The seizures will disappear and the patient will pass away. And the patient is obviously unconscious during this period. The other really ghastly one is the blowout hemorrhage. This occurs with oral malignancy because of infiltration of neck arteries, and this is something that you have to predict and be prepared for. This is hemorrhage from the carotid artery. It's not a blowout, meaning like a fountain, but rarely even that can happen. When that happens, whoever is on the spot has to stay until it is over. First is applying steady pressure and quick sedation so that the patient is asleep, while you kind of make sure that things don't, that there's no panic and, delirium in the relatives. If somebody symptoms cannot be controlled, then we need to go in for palliative sedation. Now, palliative sedation has some parallels with euthanasia, but is very distinct ethically. You are basically aiming at light sleep and comfort. You are not changing the natural process. It goes on at its own pace. You uphold the sanctity of life, but you may, in doing this, hasten death, because this is called the double effect. The double effect is when your effort to give the patient comfort also hastens mortality. This is opposed to euthanasia, where the intent is to terminate life and the natural process is actually stopped and taken over by actively accelerating death. So there is a fair amount of discussion about this, and intermittently in palliative care units, this is used. The family is probably suffering as much during all of this, maybe even more than the patient. So you have to address their needs. And if need be, you have to involve a proper full palliative care team. When you confirm death at home, remember that this has to be done as a formal process. If you are just in on the scene, introduce yourself, wash hands, confirm identity, watch for signs of life, response, confirm that the pulse is gone, at least for 3 minutes, and then exit and document. For palliative care teams, they also have the responsibility of collecting back unused opioids, and you do need to pay attention to bereavement. One of the first things that they need to be told is that normal grief can last up to 6 months, and it has a wave character. There are days when nothing seems right, and the person who's passed away is constantly in everybody's thoughts, or that person, or the main caregiver's thoughts, and then they come back to normal, and then again it comes, and then again it goes. During this period and the period before that, to help families through that, what you need to do is anticipatory guidance. You explain what is happening, prepare them, listen and be available to answer questions, confirm that symptom control will continue. If there are religious concerns, follow them. If there are wishes that the patient has, follow them. And if need be, you might have to organize extra help. I think this slide should have been earlier. So coming back to bereavement, remember, bereavement is a period during which mourning and grief occurs. Grief is the natural distress, and mourning is the outward expression of that. And remember that before a person passes away, there have been many other losses earlier than that. Everybody experiences grief uniquely. One of the main things is their relationship to the grief. And we also have something called anticipatory grief before the loss happens. Other types are that we define are acute, integrated, and complicated. Acute is intense, and it involves an evolving process of adapting, with symptoms typically declining. When it is integrated into daily life, in that this acute grief is a wave part of it. When it gets integrated into normal life, that's when people start returning to normal. What is complicated? Grief response that persists for an extended period of time and exceeds expected norms. The diagnostic criteria say anything that is longer than 6 to 12 months. And it's our responsibility to continue bereavement support, identify caregivers who are at risk of complicated grief, and ideally refer them to appropriate grief counselors and so on. You can also look for helplines within the community. Now, what I'm going to finish with is the understanding that terminal illness can be identified. Focus has to shift to symptom control. The active dying phase must be recognized, and the family must be prepared. Family support begins before death and continues afterwards as well. So actually, there's a small section after this, but unfortunately, I don't have the time. We'll first finish the case, and then if there is time, I might come back. Can I stop sharing?
Yes, yes. Thank you, Dr. We can take up a few questions quickly before the.
Can we finish the case and then do the questions?
Yeah, yeah. Then that will be better. Yeah, yeah. Dr. Shivkumar.
Yes, ma'am.
Over to you.
Am I audible, ma'am?
Yeah,
Yes,
yeah.
you are. You are.
Good evening, everyone. Today, I'll be presenting a case of 64-year-old female postmenopausal woman who was diagnosed with the carcinoma of cervix, stage 2B with metastasis. Presenting complaint, she came with complaints of breathlessness on exertion for 6 months and complaint of swelling over the right inguinal region for the past 5 months. She complained of burning and pricking type of pain over the inguinal region for the past 5 months. The pain started in the inguinal region, then extended to the back and the entire lower abdomen. The pain severity is a numerical rating scale of 7 to 8. The pain is a waxing and waning type. She also complained of vomiting and loose stools 5 times daily for the past 2 months. She has loss of appetite, weight loss, and generalized weakness with easy fatiguity for the last 6 months. And she also has a painless hematuria for the past 3 months. History of the illness, she had a bleeding pervectinum associated with lower abdominal pain, for which she consulted the doctor, and she was diagnosed to have a cervical carcinoma 4 years back. So she was started on chemotherapy and radiotherapy for 6 cycles, and she had chemotherapy-induced nausea, vomiting, and she also developed radiation enteritis. She developed chemotherapy-induced nephropathy, for which the drugs have been adjusted and changed. She is a known case of type 2 diabetes mellitus for the past 25 years on regular medications. She was apparently normal after chemotherapy and radiotherapy for 3 years, after which she noticed the swelling in the right inguinal region, and she presented with the above complaints. And she was again taken for chemotherapy, but she didn't tolerate the chemotherapy, so it has to be stopped prematurely. On examination, patient was conscious, oriented, and afebrile. She looks emaciated with a weight 40 kg. She looks dehydrated with pitting pedal edema bilaterally, and she's very pallor. Cardiovascular system S1, S2 here, and no added sounds. Respiratory system mild bilateral basal crepes are present. Abdomen is soft, generalized tenderness present, mild distension, and no fluid stream. Vitals, heart rate is 120 beats per minute, respiratory rate 22 per minute, and BP 110/60 millimeter of mercury, saturation 96 in room air. She had 6 cycles of chemotherapy, mainly cisplatin and paclitaxel base. She also underwent brachytherapy and teletherapy 6 cycles. Her hemoglobin was 7 grams per deciliter, and total count was 16,500. The serum creatinine was 2.5 milligram per deciliter, and urea was 46, and serum albumin is 2.5 gram per deciliter. Other investigations. Our psychosocial aspect, she was married for 30 years with 4 children, all well settled, and she also has a grandchildren. She lost her husband 2 years back. They are in a joint family. She is well taken care of by her sons and daughters and daughter-in-laws. She lived a satisfactory life and she doesn't have any guilt. Medication, she was on tablet morphine 20 milligram, TDS, which later increased to 6 hourly. She also on paracetamol 500 milligram TDS. She was also on capsule Bufilac TDS. She was on erythropoietin injection twice weekly. And for the last 3 days, because of the pain, she was started on epidural morphine. And her lowest pain score was NRS 6 after all medications. A major concern was the pain and for dependency on others for a day-to-day activities, and the improved quality of life and a peaceful death. Summary, she is a 64-year female diagnosed with CS cervix stage 2B, who underwent chemotherapy and radiotherapy. She developed chemotherapy-induced nausea, vomiting, and chemotherapy-induced nephropathy and radiation enteritis. She had metastasis after 3 years or after the chemotherapy with the right inguinal lymphadenopathy and lower abdominal pain, and she was bedridden for the last 5 days. Discussion points: how can we improve our pain relief and quality of life, and how can we a better end of life care?
Thank you, Dr.
Thank you. That was
Shivakumar.
a very good presentation.
Thank you so much. Maybe for today's discussion point, we'll stick on to end of life care aspects, how to have the conversations and how to manage symptoms, the desirable place of death, all those conversations for today's discussion. Dr. Roop, as you have to leave, or would you like to take up the question right away?
Yeah, so no, we'll continue with the discussion for a few minutes, I think.
Yeah.
Then
Okay.
So you'll ask or
So others, what do you think about all this in connection with Dr. Roop was mentioning about symptoms during end of life, the conversations, the legal implications.
sorry, can I interrupt here?
Yes,
Would
yes,
anyone put a time period to her survival? Anybody wants to prognosticate?
Yeah,
how
very
many
good
days,
question.
weeks, months? If you are uncomfortable, put it up in the chat box. We don't mind you just putting a number there. Anybody giving months?
The chats are yet to come up. I think they've just started typing. It will take 1 or 2 minutes to come up. Yeah. Just 1 more minute. We'll see.
Months, weeks.
No chat said what happened to the group today. No prognostication.
Okay, so we'll move on. Let them come back to it if need.
And I think that's the first question that we need to ask ourselves before we plan ahead. I guess that might be the first thing that should come up for discussion.
Now in minds, because this is a question that will be thrown at you suddenly.
Yes.
And it's there in the bottom. I mean, it is there at the back of their minds. Everybody. It's just that because we kind of keep moving away from it, we keep avoiding answering it. Well, it's the elephant in the room. Go ahead, let's go on.
So any response from the participants regarding how to have these conversations and how to manage her symptoms and end of life care for this particular patient, for this lady with CA cervix? Anyone?
First priority, who thinks that a pain relief is adequate? Okay, go ahead. I think we might as well speak.
I think there are no responses.
Okay.
Yeah, not adequate is
adequate.
one response.
Okay.
Anyone else? I thought we have been discussing about this end of life care, touching upon it from the beginning, and there were a lot of questions, but when the actual session came, there are no discussion points.
Okay.
She may just have few weeks left. Inadequate pain relief. Even with
pain score is still 6.
Yeah.
Yeah. So will you just have the family discussion just like that? Actually not. When you talk to them, you will first find out how much they know and how much they want to know. They're okay not knowing about it. That's quite okay. The same applies to the patient as well. Okay.
Any other points on how to improve the quality of life and how to manage her end of life care? Yes, one point Dr. Shirley told about family discussion. And as Dr. Roop mentioned, it is important to understand whether they want to have that discussion, whether they're prepared or ready to receive it, whether they want to know more about it. As we have learned in communication session, setting up the background, that we should have all the information and then invite them whether they want to know something, want to know more. Any other questions?
What is the next important goal of care? And when you go into this conversation, there is one question that ideally should be sorted out before you come out of it. What question is that? Anybody? Where is she right now?
Dr. Shivkumar, is she at home or is she in hospital?
She is at home, ma'am.
So epidural
She's
is
at home.
managed at home, right?
Yes, ma'am.
Okay. Are they able to cope?
Yes, sir. Actually, one of the son is a daughter medico, so he knows about this.
What is to be done? But
Yes.
otherwise, is the rest of the family able to cope? It also depends on whether you have access to a hospice close by, because if you don't, then there's no sense in offering it. And whether there's a palliative care team that can make regular visits. Because all said and done, medico available is only going to be able to do procedures as you tell them. They may not have any understanding of anything else.
Yes, sir.
Right?
Yes, sir. Actually, they are staying in Pondicherry. For this chemotherapy, everything, they have to go to Chennai, sir.
Okay.
So after they stopped the chemotherapy because she couldn't tolerate that. After that, she is only bedridden and she is at home only. So only one pain physician is taking care of the pain. So he visits the house daily or once in alternate days.
Okay. So
as such, there is no palliative care person available.
So you are the first palliative care physician who lands up on the spot, and you obviously are called in to see the patient, and the patient
Yes.
is conscious and looking at you.
Yes, sir.
Okay.
Yes, sir.
So, okay. Well, think that I'm the patient. What will you say as you go into the room? What will you do?
I
You're
just
in the hot
greet.
seat.
Yes, sir.
You're in the hot seat. So you have to step by step.
I'll introduce myself, sir,
Yes.
and I will greet everyone.
Yes.
And I
Sitting,
will ask.
standing.
If she is comfortable, I will sit facing her at her eye
You
level.
will be at her level, whatever it
Yes.
is.
Yes, sir.
If she's on the floor, you will sit on the floor with
Sit
her.
on the floor. Yes, sir. Then I will ask her how she's feeling and which is
Yeah.
what is bothering her the most. Is it the pain or something else? What is, or she has something to say?
You will hold her hand.
And yes, sir.
Non-verbal touch, extremely important at this stage. You will hold her hand. And you will ask her.
Yes, sir.
Yeah.
Yes, sir.
You will ask about the pain. Basically, you cover all the other areas of distress one by one systematically. And after you've done that, then what will you do?
I will just reassure whatever it takes, we'll be there and we'll take care. We will
This is the stage of the invitation. This is the stage of the invitation. Do you want to talk about anything else? Do you want to know anything more?
Yes, sir.
Remember that there's a stage in that encounter when you and the patient are alone. Everybody else falls silent. That's in some ways a magical moment. And if she's able to communicate, that moment is yours. Don't miss it.
Yes, sir.
Right? So,
yes.
Yeah. And then I mean, it obviously you will have before that checked out with the family what they feel. But typically, what I would do is at some point tell the patient that if you want to know anything, I am there to speak. Right? But if there is an element of the family not wanting to discuss this stuff like that, you can leave it open for a little later. Yeah. Sure.
Actually, sir, the family actually knows about the condition. Actually, they don't. Yeah, family knows, but they don't want her suffering. They want, because she is in a lot of pain actually.
Yeah.
Last few days, so they don't want her to suffer. So that is the main
So your
thing.
priority is to control the pain. I mean, that is priority number one.
And they know it is, she is in the last stage of her life. So they don't want to hasten the death, but at least natural death, she's like a peaceful death they want.
Correct. Okay.
Thank you, Dr. Shivkumar. I think there are a few comments also. In a joint family, it is important to understand who is the primary decision maker, and to have a plan in place in case of any emergency arising, like something like an anticipatory prescriptions. Any other questions or any other comments?
Okay. Chalo, I think I need to leave. It's 6:20.
Yeah.
Bye.
No issue. Like, we'll take it forward from here.
Okay. So I'm leaving.
Yeah. Thank you so much, Dr. Roop. Thank you so much.
Bye, everybody.
Thank you.
Thank you.
Thanks again.
So from where he stopped, I think it's important to manage the pain and other symptoms associated with end of life care. Or in this particular patient, I guess We need to titrate up morphine a little bit. I don't know whether she had any toxicity, and that is the reason why it is on 20 milligram TID. But if there is no toxicity, if the patient is responding to morphine along with epidural, you can give SOS injections of morphine for breakthrough pain, or you can increase the rate of infusion if there is no toxicity, if that is the case. But that is not really clear in this. And as Dr. Roop was mentioning, all those symptoms, we have to keep it in our mind that towards the end of life, patient will have change in their breathing pattern. Most of them will have noisy secretions. So the important part is, like, if they are not prepared, if we are not telling them beforehand, they'll start panicking when that time comes. When the patient's breathing pattern changes, we often get calls that, oh my God, he is breathless. He has some difficulty in breathing. There is a lot of noise when the patient is breathing, and they might rush the patient to a hospital. So what we do here is to prepare the patient and family beforehand that there are chances that there will be a change in the breathing pattern, which is quite normal when someone is approaching the natural death trajectory. There might be noisy secretions, and we'll tell them why these noisy secretions happen. As Dr. Roop mentioned, it is because of the pooling of secretions behind the posterior part of the oral cavity, where they are not able to swallow it. So position change, and if needed, we can prescribe injection glycopyrrolate. So all these will be given, and we'll be preparing the family about because they are not aware of how this is going to happen. What is the process that takes place when someone is dying? So it's very important that we give them that information beforehand, and we give something like an anticipatory prescription that if he is breathless, please give this medication. If he has noisy secretion, these are the things to be done. So everything will be written and given, so that when the time comes, they are not really anxious, or they are not really panicky, because they know that this is what the doctors and nurses have told us, and this is okay, this is normal. The patient is not struggling. So that is how we manage death at home. And as Dr. Roop mentioned, the documentation of death is different in different places. In our state, in the state of Kerala, you don't need a doctor to go there every time and certify death. They can get the death certificate done by the administration from the corporation or municipality where they belong to. They don't need a doctor's certificate as mandatory for registration of death, but that varies from state to state. So that is one thing that we need to. Sometimes people do ask, we will be thinking, how can we discuss about the deaths verification, certification, and formalities when someone is not actually died? I mean, they are there, they are still alive. But many a times, as Dr. Roop mentioned, that moment of silence is something really, really important. The moment you start asking, what is that, do you want to know more about it? Is there anything that you want to discuss right now? They have come up with all these questions. What if something happens? Whom should we call? Who will come and certify the death? Who will give the documents? Because they want to arrange things in a practical sense. Many of them ask these questions, and we will be reluctant to bring the topic. We'll be reluctant to talk about deaths. Many a times we'll keep beating around the bush that time is not really good, etc., etc. But many a times they want specific answers. It is okay to use the word death while having conversation. That's what we encourage people to talk, to use the word specifically so that they can understand. When we say things are bad, it has a different meaning for different people. They might think it is like something like a last admission where she was breathless and things are bad. She'll be back to normal. But it is very, very important to use the word that I think the patient there is a possibility that they are actively dying. That bringing up that word dying is very, very important. It is very difficult from many medical professionals, but that specific information is what usually patients and families want. So I think at least from now onwards, if you are not using that word, reluctant to use the word death, having conversations around death, please start practicing it. Right? I mean, after preparing the family, if they are willing to accept all this information, it is important to give the precise information and prepare them for dying process. I think if there are no other questions, that's all from my side. And this presentation will be available and the documents on ICMR documentation on end of life care, withdrawal of life support, and a document called Blue Maple, which has already been circulated among you during the respiratory session, I guess, which is documentation used at Manipal, KMC Manipal, for withdrawal or withholding life support. That's a document that they use there for, for the purpose of documenting that. So kindly go through all these documents, and thank you so much for being a part of today's session. Shri.
Thank you, Dr. Sridevi. Thank you everyone for joining us. And that brings us to the end of today's session. And please do leave your feedbacks, because it is very important for our improvement. Feedbacks are very valuable for us. So please don't forget to leave your feedbacks. And with that note, this is Sripriya along with Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.